It's Monday, 1 p.m., and you are on your laptops, desktops, mobile phones, or who knows what else. You may be having your lunch or your dinner, depending what part of the world you are right now. I'm Pospo, and this is BRAINCAST for Mostly Learning, your 30-minute weekly fix on everything around the brain. Last week, we took a flight to Baltimore and Johns Hopkins University, where we met Dr. Paul Nestor. We had a fascinating discussion of GAMS, suicides, and the pandemic, of course. I mean, how can you forget that we're still in the middle of a pandemic, right? So this week, we move a bit higher on the map in the land of Justins. Justin Bieber, Justin Trudeau. Yes, that's Canada. No, we're not going to analyze Justin Bieber's discography. Thank God. With me, Dr. Christian Schulz-Quach, an assistant professor and clinical educator at the University of Toronto, but also clinically active palliative psychiatrist at the Division of Psychosocial Oncology. Starting from his motherland in Germany, he roamed around the world, including Harvard and King's College here in London. And while I'm struggling to finish even one article, he's written around, let me see, like 20 books. But it is his focus on death awareness and mortality salience in healthcare professionals that brings him here today. Now, you would rightly wonder, Pospo, are you talking to yourself? We cannot see Dr. Schulz. Well, neither can I. Technical difficulties sadly rendered his camera utterly disabled, which means you will have to look at me for the whole half an hour, but you can hear him. Christian, willkommen. I'm afraid this is where my German stops. So how are things in Toronto?
Well, thank you very much, Pospo. I am so utterly sorry, and I'm already grieving the loss of my camera image for our group today. So thank you for having me.
It's okay, man. I mean, what can we do? But at least we can hear you crystal clear, and that's the most important thing. So let's start with the basics, Christian. You're a palliative psychiatrist. So what does this mean? How does a palliative psychiatrist spend his day?
Well, so from a clinical point of view, I am basically working in the biggest cancer center here in Canada. And what I do on a day-to-day basis, we approximately on an annual basis see 10% of all our in and outpatient cancer patients. And part of my time is spent in inpatient wards. Part of my time is spent with outpatients currently during the pandemic via virtual care. And we work from the beginning of diagnosis until sometimes a positive end and cancer survivorship, and in other cases with our division of palliative care and psychosocial oncology with patients who have life-limiting cancer experiences.
Wow, okay, so now I'm gonna read straight from your article, which apparently is beautiful, The Nakedness of the Dead Body. So you say there that the modern man has reasonable grounds to expect the dying process to be socially embedded in an experience of care and increasingly managed by professionals. Now, the pandemic changed all that. Patients trapped in isolation, helpless, anticipating for the worst, at times even unable to even communicate with the doctors, and most tragically, with limited access to the outside world and their loved ones. So how does this affect one's experience of death?
Okay, so first of all, I think it's important to mention that the article you're citing from is basically speaking from a sociological perspective and the perspective of technologization of death, how over the past 100 years, we've basically come to a situation where death is no longer primarily experienced in the core family, in the core community, and accompanied by mainly religious rituals, but it has become more and more a situation situated in professional context. And that means, now I'm also losing my voice, funny.
I wish I could give you a glass of water.
Thank you, it's coming back. So in this situation, we're finding ourselves with more and more professionals being involved in taking care of the dying and those who have life-limiting illnesses. Second, I want to mention, however, that you cannot really experience your own death. That's an oxymoron. It's not possible to be experiencing whilst your own death happens, because where death is, as we know, you are not, and where you are, death is not. But what we can do, and what we unfortunately are doing at the moment on a global scale, is we can witness the death of the other. We can witness the death from a second person, and the death from a third person perspective. The difference being that the second person perspective is someone who is close to me and who is important to me. And the third person perspective would be the person who I'm aware of that they're dying and that they're dead, but they are not related to me. Robert Niemeyer, in this context, who is a famous Northern American grief specialist, at the moment talks about ambiguous losses, and we are experiencing them on a large scale at the moment. Ambiguous losses as a precipitator for grief are those losses where we aren't 100% sure whether we've lost something or not. And so I want to just mention this as one very, very important aspect of our current experience. And we do not know what the future will hold. We do not know what the new normal will be. Are we going to be able to go around the corner to our pub we liked to use to before? And so the loss we're experiencing, such as our social rituals we were embedded in, is unclear. It's ambiguous. And that creates a very particular kind of grief.
And I mean, the other thing is that, so not only these patients, they're faced, with the definite end, but also it seems that, they had to make really important decisions, on the spot. So they had to make wills, issue advance directives, and that doesn't seem to be really helpful in the whole process. It brings an extra stress, no?
It does bring an extra stress, evidently so. And at the same time, for those who work in palliative care, in end-of-life care, in psychosocial oncology, or just those who work in medicine on ICUs or emergency departments, we are all aware that it's an existential given that life is fragile. And that means that most healthcare professionals working with death and dying, they know that we often encounter this very phenomenon that people say, well, I am so surprised. I never knew that my husband, that my friend, that my son who had a long-term illness or a life-limiting illness is going to die. Well, from an existential perspective, we always are in a situation of fragility and of potential end of life. And so advanced care planning is what has developed over the past 15 to 20 years as a communication model, as an idea, as a process of talking about the end of life before it actually happens. And this is something that we need to take more seriously going forward, maybe as a consequence of this global pandemic, because otherwise we run at risk, and unfortunately we're experiencing it in many people today, that we're experiencing something that's called disenfranchised grief. A grief where, because we haven't had an opportunity to talk before, because everything has to be decided on the spot, we find ourselves having to make hastened decisions and possibly even finding ourselves in traumatic situations.
And I mean, on the other hand, of course, you have the relatives unable to even to talk. I mean, I'm not even saying touch, the loved ones. And we all heard these, horror stories. And some of the people watching us may have had firsthand experience of funerals and burials being postponed, or even held remotely without the presence of the loved ones. So how important is saying goodbye to the people you love?
Well, I want to take a humble position here. I think importance is something that can only be decided individually. For some people, it is really not important to say goodbye to their loved ones because they don't love the ones that are close to them. At the same time, for many, many people, it is extremely important to say goodbye and to have an opportunity to speak about the end, the closure of a relationship, be it in a more sociological sense or be it in the sense of actually saying goodbye for someone who's going to die. There is one national survey that's quite important to mention here by Otani in 2017 in the Journal of Pain and Symptom Management, they actually looked at this and looked at meaningful communication before death. And they looked at whether someone had an opportunity to talk about death and dying prior to the death of a patient, and whether this person then was able to be present at the point of death. And the interesting point was that those who were not there at the point of death, but who had an opportunity to meaningfully converse about dying and death with a person with a life-limiting illness, they experienced significantly less complicated grief or prolonged grief disorder. So again, it seems to be important to have an opportunity to say goodbye. It does not seem to be important to say goodbye at the very last point or moment in time. And as a matter of fact, those of us who work in the field know that it is often, unfortunately, in 80% of cases, not even possible because people have terminal delirium or they are too sedated to speak.
And since you mentioned you brought in the professionals, in the discussion, many times, especially during the pandemic, doctors, generally healthcare professionals, had to take extremely difficult decisions, essentially deciding on the spot who lives or dies. At times, even against what they feel is right, resulting in the concept of moral injury. So isn't that also a form of loss and grief for the healthcare professional?
So I guess, first of all, I want to answer by saying that grief is an inherent part of our experiences as healthcare professionals. So to speak, it's a normal part because we experience loss all the time. Loss of patients, loss of choices we no longer have, or in this case, you're talking about the physical or emotional suffering that we experienced when the course of action that we need to take is not the course of action that we believe in. And this is exactly what you call moral injury, or we call moral distress. And this moral distress indeed can lead to a sense of loss, the loss of choice, the loss of the right course, and that then in itself can lead to grief. I want to maybe use this opportunity right now to speak a little bit about complicated grief. What is complicated grief? I just said grief is an inherent part of our work and therefore is something that will happen on a regular basis, normative. But when it becomes complicated, it can potentially also have mental well-being implications. So complicated grief is, as we just discussed, an inability to say goodbye to whomever or whatever we have lost. It's also related to low levels of social support. So if we feel that in the situation we're experiencing our losses, we did not have the social support we needed or desired, we can have complicated grief experiences. If there is a lack of preparation for death or the loss of an object, and when we have strong feelings of guilt, all of those aspects can create complicated grief on top of having very strong pre-loss grief symptoms, as in anticipatory grief. When our anticipatory grief is very, very intense, then this can also be a predictor for complicated grief.
No, thank you very much. I mean, one of the things that many of us find extremely difficult is to break the news. So how do you say things that may hurt? So are there any pearls of wisdom that you can share as a palliative psychiatrist? Or in the end of the day, we're all thinking about it too much, ending up, losing our human touch.
Difficult news are always difficult. They're always hurtful. They're always painful. This is nothing we can take away by way of communicating in the right way. We can, however, do one thing. We can allow a person to feel this little bit more prepared for impact. This is a psychological buffer that we really need to facilitate for people so that we do not traumatize them by the way we deliver difficult news. One model that is widely used, and every medical student, every nurse hears about it at least once nowadays, is the model of spikes, SPIKES. and it has been adapted for palliative care as a Spikes P model, where advanced care planning becomes part of the communication model. But basically what it means is setting up the interview in a way where you will not have your pager go off or your bleep go off. Next step, assessing the patient's perception, making sure the patient understands where you are at and that you are going to discuss with them now something difficult. Obtaining the patient's invitation, making sure that the patient is at this point in time ready to talk about it and does not want, for example, their wife or their husband who are waiting around the corner to be present in the conversation, which would only take 30 seconds but could shift the whole psychology of the moment. Giving knowledge and information to the patient, so actually providing the difficult news once invitation has been accepted. And the fifth step would be addressing the patient's emotion with an empathic response, ending then with a summary of all of this. I guess I want to say one thing. The most important thing is to actually invite a person to have this conversation, to simply ask, can we move on with this conversation? Can we talk about what's important right now? And to really request invitation acceptance. And the second thing is to really, once you have concisely talked about the difficult news, to be silent, to be quiet, and to actually wait until an emotional reaction is displayed.
Okay, thank you. That's really helpful. Okay, let's open the door. Let's open the door and let's move outside of the hospital. But to be honest, I can't really remember how that feels like, to be honest. So we accustomed ourselves, and I'm talking about the society in general, to hearing deaths as a number. So charts with names of countries on one column and number of deaths on the other, as a dark football league of the other world. So are we getting desensitized to death? Are we somehow disrespecting the people grieving their loved ones just by putting numbers next to deaths?
Well, it is a fact that we need to, and actually we need to communicate about those numbers so that we can prevent the numbers going higher than the absolute minimum necessary, unfortunately. Bereaved individuals, however, may indeed grapple with the fact that the person they've lost was so much more than a statistic, and they might find that it is very difficult fitting their grief within these, if you will, societal messages of news articles and news updates and breaking news. All of this can lead to disenfranchised grief. I spoke about it earlier already, to a sense of grief not publicly or socially being sanctioned or publicly mourned by a larger community. And so it is extremely important to remind ourselves on a regular basis, also from a governmental perspective, that a huge portion of society is currently going through a grief process.
And we've been talking all this time about loss, and you actually hinted about that a bit earlier, that what this pandemic actually brought in our lives is multiple losses, and there is notion of the primary and secondary loss. So can you tell us a bit more about that?
So the idea of primary and secondary losses is pretty simple. Primary losses are the big losses, if you will. They are the primary, well, they are the main losses. They're associated with significant events, such as a death or a major life change. And the secondary losses are the consequences of those primary losses. So those things that are often overlooked because they seem covert and early on and only emerge later on. So I'll give you an example. I mentioned it very early. Being on lockdown in many cities around the world, although we're slowly seeing an opening up, is a primary loss. It's a primary loss of social reality. And this loss of freedom can lead to secondary losses, such as losses of relationships, of recreational time, social support, my pub around the corner, my art museum I like to go to, or just the regular walk I used to take on a daily basis. These secondary losses can be even more powerful because they are typically speaking more to what's meaningful to me as a person on an individual basis. And this is very, very important because the secondary losses are the things we feel most significantly in our day-to-day mourning at the moment during this phase of grief.
Now, since you mentioned grief and you talked a bit about, complicated grief, let's talk about, the normal grief. It seems that it comes in stages, right? So can you talk about that a bit more? And also I can read a question by one of our attendees, Ahmad Abraham, that asks, so what is best practice in managing complicated grief? But the most important thing is, when does it become clinical depression or adjustment disorder? So let's start first, with the stages of the normal grief, and tell us, if you can, a bit about what's different between grief and depression.
Sure, I'm happy to do this. So as most listeners might know or might not know, Elisabeth Kübler-Ross was the first person trying to systematize grief reactions, and she came up with those very famous 5 stages that we've been talking about for decades. And then there was a counter movement saying those 5 stages: denial, anger, bargaining, depression, and then acceptance, are not really an arc, and they're not stages. They're just descriptors of temporary phases of psychological integration of a loss of object. And what that means is that nowadays we still do feel that those steps can be often identified in the process of losing attachment and the process of saying goodbye, of grieving. But they are by no means one after the other in a serial fashion. So people can oscillate between one and the other. There is, however, also a proponent who is talking, Mr. Kessler, who is quite well known for his grief studies, and he's published with Elisabeth Kübler-Ross. He says that meaning is a 6th step of grief, which we need to integrate into the model to better understand what's really happening. So people creating a sense of meaning once they have accepted what is going on. But there is also one other model that I just want to very quickly mention. It comes from our Disaster Psychiatry Canada team. And this is the idea of how, on a more large scale level, a society reacts to pandemics or to large scale disaster. And that's after the impact, there is a heroic phase, which is then followed by a honeymoon phase in which there's a very strong sense of community cohesion. And we just experienced this in many countries, and especially in healthcare. And then there comes a disillusionment phase. And I think we're starting to see this disillusionment phase increasingly now, leading up to the anniversary reaction, which is approximately 1 year after the incident, after the main incident, when people have very strong anniversary reactions. And then afterwards, the reconstruction phase, in which people go back to something which has felt like the new normal. Yeah, go ahead.
Well, what I find interesting, though, that for most people, uncertainty is what brings on anxiety and stress. And as we know, the world, is rife with uncertainty, which makes it a breeding ground for stress. Now, the only thing, though, that's certain in this life is death. So is it the absolute certainty of death that creates anxiety, or the uncertainty of when it will knock on your door?
So I will very quickly answer the question of the gentleman in terms of what's the difference between grief and depression. I just want to say the main difference that I just want to quickly speak about is the difference that in grief, people are focused on the loss, whereas in depression, the person is typically focused on the self, on oneself. So the main difference is this, and then there are other elements of difference, mainly being a fixation on an emotional fixation of feeling stuck in depression, whereas in grief, there's often a retained ability to show reactive affect and have a range of emotions, and especially also the central core element of hedonia, the ability of feeling joy in the here and now moment. Someone who's grieving is often still able to experience a sense of joy in the here and now, whereas a depressed person would not typically be expected and would have an inability to feel pleasure. Now, going back to what you just asked, Pospo, according to existential philosophy, it will very much depend on how high we feel in our existential anxiety, or it will depend on what our degree of ideal self is that we have achieved in any point in time. So here at this moment with our global COVID-19 pandemic, the question is, am I in a stage in my life where I feel I've already achieved a lot? Or am I in a situation where I have a lot of regrets about my life or the life decisions I have taken? Because my life is put on hold and I can currently not really take many choices. I can't really do much. And so it really puts me in a position of having to reflect upon my life decisions, and where I am in life. And Robert J. Lifton is one psychoanalyst who looked at this and called it symbolic immortality. He speaks about the 5 modes of how we can achieve a sense of immortality symbolically when we know that we are mortal and when we know that physically we're going to die one day. He speaks of the mode of biological survival in terms of having offsprings and having close-knit family systems in which our stories will live on. He speaks about the religious mode, where people are deeply believing in an afterlife. He speaks about the artistic mode and surviving in work of art or pieces of work, such as wonderful webinars and podcasts that will survive even when we're no longer there, Pospo. And then the mode of oneness with nature, walking in the park or walking along the seaside when we're feeling low. And the 5th mode is the experiential transcendental mode, which speaks more to a sense of spiritual transcendence.
Amazing. Christian, one last question. A good death. Is there such a thing?
Well, I'm the wrong person to answer this. As a matter of fact, I can only give a very quick personal answer. I've read a book by Vladimir Yankelevich. It's actually lying behind me. I would have hoped that you could see it. There is no English translation. It's called very helpfully Death. I think from my personal point of view, there is only something like a good death of the other, the death of a second person, a good death of the one we love, we care about, and making sure we talk about it early enough in a way and fashion that allows us to plan ahead a little bit more than just being surprised by it.
That was extremely interesting, Christian. Thank you so much for taking the time to join us today, even without a camera. Next week, we're flying back to London and the Institute of Psychiatry, Psychology and Neurosciences, where we find Dr. Marta Di Forti, one of the most active clinical scientists in the field of cannabis research. We're going to talk about molecules with really difficult to pronounce names, brain receptors, and psychotic experiences. Yes, we will touch on how the pandemic affected cannabis use, don't worry. See you all next Monday at 1 p.m. Until then, Pospo for Mostly Learning, over and out.